You're listening to Clinical Conversations. I'm Joe Elia. This time we offer the third in a series of 4 interviews on race and clinical equity. In this series of brief chats, we're talking about equity in clinical medicine, the lack of which is a situation that too many Americans face. With me is Dr. Karen Dorsey Sheares, an associate research scientist in general pediatrics at Yale, and a director of the Yale New Haven Hospital Center for Outcomes Research and Evaluation. Welcome, Dr. Sheares.
Thank you.
Could you tell us a story that illustrates the problem of inequity in clinical medicine?
I have many stories of inequities in clinical medicine. I think one that's relatively well told is a story about my participation in providing clinical care in the newborn nursery at Yale New Haven Hospital. There, as a general pediatrician, I rotate through the well baby nursery some weekdays, some weekends, along with my colleagues to cover the wellborn service. And since the time that I came to Yale New Haven about 20 years ago and became an attending and have performed that service, there's been a policy in place at Yale New Haven Hospital about how to handle mothers who either report or test positive for marijuana use during pregnancy. Mm-hmm. And being a little bit of a student of the world and living, inhabiting both white space and black space, I'm aware that most white women who engage with obstetrics care don't ever get asked if they use marijuana, and certainly don't ever get tested for marijuana during pregnancy. But many of the women who deliver at our hospital come through the Medicaid care clinic at the hospital, as do many of the pediatric patients in the clinic, in the part of the clinic where I provide outpatient care. And as a part of a routine, they are surveilled for drug use and tested for drug use during pregnancy. And so there's a surveillance bias of them being identified as being marijuana users. And women use marijuana for, 2 main reasons I find during pregnancy. One is ongoing use to manage anxiety, which is a pretty common reason that women use marijuana. And the other is because marijuana can help with nausea and emesis associated with pregnancy. So because these women come to attention and they're known to have used marijuana during pregnancy, at the time of delivery, there had been a policy that had 3 pieces to it. One was that the woman would be screened again at the time of delivery when they come in for delivery, that the baby would be screened. So they would put a bag on the baby to screen the baby for exposure, and the mother would be not allowed to breastfeed in the hospital, and her case would be reported to the Department for Families and Children in Connecticut. And I've found this policy quite problematic. As an attending, as a junior attending, I raised that issue with my colleagues from time to time. When I would cover the service, I would not sign orders to have the baby tested. I would try to reassure my colleagues on the floor that if the mother was positive, then the baby was certainly exposed. We didn't really need to test for that. We could feel pretty confident of it. And that I did not make DCF referrals for marijuana use myself, but of course, multiple providers make their own decision about whether they're going to refer or not. And then I would always encourage mothers to breastfeed, as I do all mothers, unless there's a strict contraindication for certain types of rare infections. And of course, would recommend to them that they abstain from marijuana use during the time that they were breastfeeding, much the way we would talk about tobacco use. And for years, I would complain about this policy, but as a junior faculty member, wasn't really in a position to change it. And it became more and more difficult for me to manage that cognitive dissonance over time, especially as marijuana became legal for recreational use and medicinal use in many places in the country over the intervening decades. And a few years ago, I just really could not take it anymore. And I wrote an open letter to my colleagues, explained to them why I could not adhere to the policy anymore. And that prompted a meeting at one of our section meetings where we had a really challenging conversation. And people who had engaged in remaking the policy, which it had been remade since I had started complaining about this, but not much, really feeling like they were being called out for racism. And I tried to be very direct about the impact, but not be personal about ascribing racial intent to anyone. But it was, it was a challenging conversation, and finally the policy was removed. Although some people who've practiced in our hospital for a long time continue to make reports to DCF. And again, it's not part of the policy, but many people have the discretion of reporting. And DCF, to their credit, has changed the way they respond to marijuana reports at the state level, which is a nice thing, but it is still something that really damages the clinical relationship with mostly Black and Latina women delivering at the hospital.
Yeah, so it illustrates the kind of differential enforcement of a rule in one instance, and then in other instances, differential withholding of perhaps treatments, which we'll get to later because you've done the study on that as well. You've conducted research on childhood obesity and activity levels.
Yes.
And so are there any lessons on equity to be found in that research?
Certainly. Like most pediatric sort of, I don't call them disease states, but barriers to wellness and barriers to lifelong health optimization. Many of them have their roots in poverty, and unfortunately, in many places, including the places I've practiced in my career, in racialized poverty, which is the combination of poverty and economic divestment, sort of public economic divestment, focused in certain racial groups, and in particular African Americans, but also increasingly over my lifetime, Latinx communities as well. In New Haven, redlining was very much in practice during the time of redlining. And when you look at old maps of redlined New Haven and you lay them over the current communities that are majority Black and Latinx, you see a very direct correlation. And so for obesity, similarly, where you have generational and government-sponsored economic divestment in communities is where you see food deserts, is where you see non-walkable neighborhoods, is where you see real safety concerns around the use of public space, where you see the most dilapidated school facilities, and so on and so on. So those things connect directly to children's ability to be outside in the places where they normally accumulate physical activity, and to have healthy diets. So those things overlap greatly.
Yeah, and so those playgrounds, for instance, aren't kept in good repair, and there's no place for kids to go out.
Right.
Presume that they can play baseball someplace. Right. When the weather turns, or to take up running. You mentioned colleagues, and so without referring to your own colleagues, but speaking about clinicians in general, is there something that you wish they would do differently to address the inequity problem at a personal level, not at a policy level, but personally?
Yes, I think that we are a very studious and learned group as physicians. We got to this place in our careers because we are not afraid to spend a lot of time with books and journal articles, and to think critically about information, and to be, to bias ourselves towards evidence-based inferences, and to guide our actions accordingly. And somehow, we're still not impervious to the American sort of cultural blind spot around racial politics in our country. And so my wish is that sort of beginning in the pre-med space, that folks who want to practice in this service-oriented applied scientific field would understand that they need to be students of the people that they serve and the nature of the institutions that they work in, and that we need to understand that as clearly as we understand the pathophysiology of coronary artery disease, because it is just as critical to achieving good outcomes for our patients that we are fluent in those kinds of dynamics that drive health outcomes.
In the 19th century, Rudolf Virchow, the founder of cellular pathology, said that medicine is a social science.
Yes, that's right.
And it resonates today, especially. So getting back to something we talked about before, I looked at your 2019 article in Health Services Research, and it proposes a method for measuring health-related disparities, not from one region of the country to the next, or not from one hospital in a city to the next, but within a given hospital.
Mm-hmm.
And can you tell us a bit about that work and what the follow-up to it was?
Yes, certainly. So I can say I was not the lead. The work that we do is incredibly collaborative at my organization, and my colleague Susanna Bernheim was the lead for that work, although I was involved, obviously, as an author on that paper. And what that seeks to do is to try to so we work in a place where we believe that revealing gaps in quality through the transparency of revealing gaps in quality using metrics and sort of empiric analytic approaches, that we can create incentives, both moral incentives and financial incentives, if those metrics are used in value-based payment, to drive quality improvement. And so the idea behind this is to say, if I understand as an institution that I have a performance gap when I look at my lower income and higher income patient population separately, that gives me important information that helps me drive, be incentivized, be motivated to change that, to narrow that gap. If I don't know that, if that's invisible because I've never looked at it, nobody's ever developed a methodology to help me understand it, then it's just baked into the cake and I might not even notice it and therefore not have any ability to change it. So the idea here is to reveal some of the performance differences that can occur even inside of an institution when caring for patients who are lower and higher income. And it's not strictly a model conceptually about doing less or not doing the same for a lower income and a higher income patient. It can equally be about not addressing the special needs of the patient who lives with a lower income, and therefore missing an opportunity to really optimize their health because you weren't quite attending to the special need that they have, whether that's appropriate language services or a really important aspect of care coordination that has to do with the housing limitations they have and so on.
Yeah, and so you looked at social. You took into account social risk factors.
Exactly.
And the outcome that you were measuring was readmission within 30 days, I think. And you looked at Medicare and Medicaid. And so your conclusion was that there were, I think, three factors: dual eligibility, so somebody who's eligible for both Medicare and Medicaid, African American race, and I think that was it. And those two factors were associated with higher readmission.
Yes, that's right. And, we've seen that as a trend, when we compare hospital performance across hospitals, not within hospitals, but this was an observation of the same within hospitals.
So is there something that you wish everyone would read as a kind of, I don't know, I mean, there are many Bibles, I guess, out there, but as a kind of a general introduction to the problem of inequity?
There are many things. I will say that there are many layers and complexities to why we find ourselves at this moment of inequities. I say often when I teach the medical students and I'm talking about my identity that, I'm a African American woman, a Black woman who doesn't look phenotypically Black, and that's an interesting experience and walk in life. But I'm also somebody who I was raised by parents who really intentionally prepared me to work and operate in white space. And that's not true. That's not a universal experience among Blacks, but my parents were certainly motivated to have me, be right where I am, a professor at a top university. And so part of that preparation has been a life of study of racial politics in the West and in America especially. And so I've consumed a lot of writings and literature about this. And I don't really think there's one approach. Some of what I recommend to people depends on where they're starting. So I think if people, especially my white colleagues, really have not, begun anywhere to read, then I ask them to read a couple of books by white authors. I think sometimes it's easier to hear a message for a white audience written by white people, and I ask them to start there. And then, once they've sort of had an introduction to some of the ideas about racial politics and how they come to it as a white American, I encourage them to read from Black scholars. Some of the things at the top of my list for introduction is White Fragility by Robin DiAngelo. I think that's really well written from a white author for a white audience. And then there are many Black scholars that I recommend. The most recent book by Isabella Wilkerson, Cast, is just a tremendously powerful insight into Western racial politics and especially the American instance of that. But there are many more authors. Ibrahim Shendi is one. Many who have really thoughtful, provocative takes on this subject that really help. For physicians, medical apartheid. I teach the medical students that they're operating in a system of apartheid that's always been a separate and unequal system. And so reading Medical Apartheid, I think, is a really important historical look at the origins of our separate and unequal health system that we're sort of living with the legacy of today.
I read The Half Has Never Been Told. Mm-hmm. It's a history of the role of slavery in American economics. Mm-hmm. And I was surprised and stunned to learn that there was a kind of a market crash in the 1830s, I think, when the price of slaves who were invested in as a group, as a commodity, yes, crashed because of the introduction of the cotton gin. Cotton gin, yeah. Mm-hmm. And those investors were not limited to people in the southern states.
That's correct. Yes.
Those investors were from. I'm from Lawrence and Andover, and there certainly were a lot of investors up there. And I hope that they lost all of their money, but they didn't. So. No.
Yeah, that's not quite how it worked.
No, that's not quite how it works.
Yeah.
This has been a very interesting conversation, Dr. Sheares. Do you anything you wish I had asked you that I didn't?
No, I like to always, when I'm talking about this subject, say that we're in a tumultuous moment, but I have a lot of hope in the moment because I see signs around me that when confronted with this idea that our progress and our holding on to our legacy racial political system, our intention, that a majority of people really want progress. It doesn't make it easy to let go of that, But we're starting to really tip the scales where most people really want to press forward, whereas I think, people wanted a little bit of incremental relief in, the last 2 centuries, but weren't really quite ready for progress and the letting go that's needed. And I see that really shifting right now. It's a tense shift because the people who say, no, holding on to our old political system is more important than progressing as a people, are very dug in and sometimes violent, always have been, had that potential for violence. But I think the scales in terms of who's in the majority are really tipping. And I think that means we have a coalition of people who can really make a change. And that's what I'm hopeful for.
All right. Well, I want to thank you very much, Dr. Sheares. It was lovely to meet you and talk with you. And thank you for your time today.
Thank you. Thank you so much.